Hello, this episode is focusing on accessing administrative data without consent, the legal and ethical considerations. I'm Fiona Lugg-Widger, Deputy Director for Data at the Centre for Trials Research here at Cardiff University. So let's start with what we'll cover in this webinar. First, I will define what routine or administrative data is and why it's so valuable in research. Then we'll look at the role of consent, why it matters, and when it might not be required. I'll cover the legal and ethical frameworks that govern this area, particularly in the UK, and I'll provide an example of a study that I was involved in that covers the use of linked data without explicit consent. And finally, I'll share some practical steps that you can take to ensure your research is compliant and ethically sound. So to start, what is administrative data? So routine data or administrative data refers to information collected as part of everyday administrative processes, so not specifically for research. There are many examples. I've got some here on the slide. So we've got NHS patient records, school attendance and attainment, tax and benefits records, social care assessments, which could be for children or adults, police, criminal justice data, as well as information about the workforce. So these data sets can be made available at a national level. So in some cases, they are submitted via local authorities or health boards and then sort of fed up nationally and can be accessed and made available on a national level. So using these data for research has huge potential, and linking information together across the sectors can bring even more insights into the populations that we're interested in. This information does differ to questionnaires, surveys, interviews, because this information has been collected as part of delivering a service, so it might not have that granular information that we're used to collecting from other data collection methods. But it does remain a powerful tool and must be accessed, analysed and disseminated responsibly. So consent is a foundational principle in research ethics. It reflects respect for individuals' autonomy, their right to control what happens to their personal information. Informed consent means participants understand the purpose of the research, what data will be used, how it will be stored, and any risks involved. But in the context of routine administrative data, especially large or historical data sets, obtaining consent from every individual may be impossible. For example, if you're analysing 20 years of hospital records, many patients may have moved, passed away, or never provided contact details. So that's why there are exceptions, but these are tightly regulated and must be justified. So there are three main scenarios where consent may not be required. The first one is anonymised data. So if the data has been stripped of all identifiers and cannot be linked back to individuals, it's no longer considered personal data under the data protection regulations. So as an example, a researcher is analysing anonymised A&E admission rates to study seasonal trends. So they have no access to names or addresses or dates of birth, and instead they have a data set where they have an age at admission that's been calculated and made available to them, alongside a code to indicate a deprivation score for the patient's location. The second scenario is public interest. So if the research serves a significant public benefit and the risks to individuals are minimal, it may be justified. The example here would be during the COVID-19 pandemic, where identifiable health data was used without consent to track infection rates and vaccine effectiveness. In all cases, the use must be proportionate, necessary, and still subject to oversight. And the final option here is where it's not feasible to obtain consent. And this may be due to the size of the data set, the age of the records, or the lack of contact information. And researchers may apply for an exemption, and I have an example of this later on in the webinar. And so just to add here, that understanding the difference between anonymisation and pseudonymisation is important within these scenarios. So anonymised data means that all identifiers have been removed and individuals cannot be re-identified, even indirectly. And this data is not subject to data protection regulations. Pseudonymized data, on the other hand, has identifiers replaced with codes, but can still be linked back to individuals with additional information. So, for example, a data set with NHS numbers can be replaced by random IDs, and that would be pseudonymized data, not anonymized, if that key between the ID and the NHS number still exists. So this distinction does affect whether consent is needed and what safeguards must be in place. So let's look at the legal landscape in the UK. So the UK GDPR, so General Data Protection Regulation, and the Data Protection Act 2018 govern how personal data can be processed. So for research, the lawful basis is usually that the processing is necessary for a task in the public interest. But even if data is lawful under GDPR, it may still breach the common law duty of confidentiality. So this duty applies to information given in circumstances where it's expected that there is a duty of confidence that would exist. And even after death, information about an individual remains confidential under this common law. And there needs to be a reasonable expectation that this information would be shared in order for it to be shared. And that's then where Section 251 of the NHS Act 2006 comes in. So for health data, this allows researchers to use confidential patient information without consent, but only when they have Section 251 approval, which is granted by the Confidentiality Advisory Group. And I talk about this a bit more in my example. So Section 251 applies in England and Wales, and there are equivalents within Scotland and Northern Ireland. And even when consent isn't required, there still needs to be ethical oversight, and this is essential. So ethical oversight ensures that researchers are held accountable and that public trust is maintained. So we've got research ethics committees. So that could be an NHS ethics committee or one of the university school ethical committees. And they will assess whether the study is ethically sound and whether the use of the data is justified. If you're using health data without consent, you'd also need approval from the Confidentiality Advisory Group, which is based within the Health Research Authority. And these bodies look at whether the research is in the public interest, whether the data use is proportionate, and whether risks to individuals are minimised. There's also additional oversights provided by, for example, the data providers who make their data available under a data sharing agreement. So often we submit an application to request that data, and as part of that application we're required to state the public value of the research, any risks of identification, and what our plans are for working with that data. If we're accessing data via a trusted research environment, or sometimes called a secure research environment, data safe haven, there are other requirements that we are also required to adhere to. So, for example, researchers are required to undertake safe researcher training or become a registered, accredited researcher before we're allowed to access that data. So now we're going to talk about an example of a study that I've worked on, which is the Building Blocks 2 to 6 study. So this study was a data linkage study where we wanted to follow up a trial cohort for an additional 4 years after they'd finished in the trial. So the participants were mothers who were pregnant, teenage pregnant mothers who were pregnant with their first child, and within the trial they received an intervention or a comparison arm of usual care, and the trial followed them up until the children were 2 years old. And what we were interested in was following this cohort up for a further 4 years, so until those children turned 6. And The outcomes of interest that were relevant to this intervention were related to interactions with children's social care, further pregnancies from the mother, but also child health, so interactions with A&E, and then also developmental outcomes and educational and attainment outcomes. So as you can imagine, some of these pieces of information are quite sensitive, and also there remains a bias in terms of what we might ask these individuals in terms of how many interactions they've had with social care versus what might be in their social care records. We also had a challenge in that there were a large number of mothers across England who were likely to be changing their address, their contact details frequently. So it was decided that using routine data was the best approach to follow up these families for a further 4 years. Now, this diagram looks a bit complicated, and I suppose in a way it is, but this just demonstrates the data linkage process that we followed in order to bring data together from various sources. So some of the information on here is a bit out of date. This was published in 2018, back when NHS England were referred to NHS Digital. And also at the time we had to access death data via the ONS, whereas now it is available from NHS England. So, but the general concept would remain the same in current day. So we were in a position where we had the identifiers for all of the trial cohort, and so we requested ethical approval to allow us to transfer those identifiers to a number of different data providers to link and identify records related to these individuals. So that was the health data, that was education data, death data, as well as abortion data for the mothers. And so we put in our requests to each of these data providers to allow us to access those data of interest. But to allow us to do this, we also applied to the Confidentiality Advisory Group for Section 251 approval to allow those identifiers to be moved from the trial, which was held on the University Secure Server, to move those information to the various data providers. Once that data was transferred to the data providers then appended the data that we'd requested. They removed the identifier and replaced it with a new ID, and then all of that information was transferred into a safe haven, a secure data environment in which we could access that data, but by that point it was anonymized data. But in order for us to get to that point, we did have to go through ethical approval, Section 251 approval, and a number of data request applications. So some practical steps and key takeaways that I've learned from that study, but also from other work that we've been doing. So firstly, assess whether the data is identifiable. And if it's anonymized, then you may not need consent. If it's pseudonymized, then that falls into being governed by general data protection laws, and so that would be classed as the same as identifiable data. Always consult your school research ethics committee, and the university now have an ethical self-assessment for secondary data, so that may be applicable here where you don't need a full ethics committee approval. You may just need to conduct this self-assessment. If you're working with identifiable health data, then you will likely need to be considering whether you need Section 251 approval, or, as I said, equivalents in Scotland and Northern Ireland. And finally, make sure you're talking to the data providers who are providing this data, so they will have their own advice on access and governance. And throughout all of this, make sure that you're documenting all of those discussions and decisions. Some best practices, so for the ethics application, for your protocol, for your data request applications, These are the sorts of things that you need to have in mind. So to collect only the data that you need. If you don't go down the route of requesting consent, make sure that you have a clear justification of why. Make sure that you're thinking about the public value of this research. Think about what this data is. Is it pseudo-anonymized, anonymized, identifiable? And make sure that's documented clearly. Think about the secure setting where you're going to access that data from, and involve the public. And as I said, make sure that all of these decisions are written down and that you can communicate those decisions clearly. Make sure that you keep on top of all of your approvals. In my example, we had a number of different data access requests and approvals and contracts, so it's good to sort of keep on top of all of those. And then there'll be some relevant documents that may be helpful for you to complete alongside these applications. So there'll be the ethical application, data request applications, a data protection impact assessment will be required, especially where it's not anonymized data that you're accessing. A data management plan would outline what you plan to do with the data, where it will be stored, all of the decisions that you'll be making about working with this data. And then, as I said, data sharing agreements that will be issued by the data providing organizations. And so just a moment on public involvement. So using data without consent does carry risks, both to the individuals and to public trust. So there's the risk of re-identification, but there's also the risk of a public backlash if people feel that their data is being used without this transparency. So that's why it's so important to communicate clearly about what data is being used, why, and how privacy is being protected. So trust is the foundation of data-driven research, and once lost, it is hard to regain. And so working with members of the public is the best way to ensure all communication is clear, explained at the right level, and is accessible to all. So here's some further reading that you can do within the Cardiff University intranet, but also external organisations. So HDR UK Futures have a number of online courses, and the ADR UK Learning Hub also has a wealth of resources, so do look at those. I think also helpful to talk to the University Data Protection Officer, the School Ethics Office, and then externally the Health Research Authority, and to look at the information on the Information Commissioner's Office as well. So just to wrap up, routine administrative data is a powerful resource for research. Consent is the ethical default, but it is not always required. There's legal and ethical frameworks like GDPR, Section 251, and research ethics, and these guide responsible use. Transparency, oversight, and public engagement are always essential. And finally, just always ask yourself, so is this research necessary? Is it proportionate? And is it in the public interest? So, diolch yn fawr. Thank you very much for listening.